And good morning, everyone, and welcome to PerfWeb 88. I'm your host, Joe Basha. Probably all of you may know me already. I don't know how many are already out there in web world, but welcome. Let me go through our basic opening remarks and get through that. You can reach us at contact@perfusioneducation.com. Send us an email, a suggestion of a topic, whatever the case may be. You want to just send us an email, ask a question, or give a compliment, that's fine too. If you'd like to be live on the air, we actually have the phone lines. We always have them on. And the one time that we didn't have them working was the one time somebody finally called us. But our number is 832-239-5358. We welcome you to call and be live on the air and discuss this topic or any topic with us for that matter. Of course, we always have this scroll bar that you see here going across the bottom. It has all of our social media, the YouTube, the FaceTime book and whatever, share us, Twitter, all of that stuff, all of the different ways that you can connect with us. Is always present down there, as well as our phone number, as you can see. Now, if you like listening to podcasts, we do our programs all via podcast, and they're available on whatever your favorite streaming platform may be. I know we're on iTunes and Spotify and Podbean and other stuff like that. Is that right, David? Did I get them all? Okay, and I think there's several more. And what's next on the agenda? Oh yeah, I'd like to show you our app if I can get this to connect. We tried doing it earlier. We had it connected. Now it's not wanting to screen mirror. It's always going to be something, right? You know, but yeah, it's not connected. It's not even seeing the computer yet. But I'd like to. Do you have an image of the app we can just go over? Because I really would like to show them this. I think this app is really I'd like to try to figure this out and figure out why it's having difficulty. But our critical care and perfusion app is located on both iTunes and on Google, the Google Play Store that you can find. And let me see if I just reset my phone for a second, because I really do want to show you these. It does some really incredible stuff. It's very good for in the morning. You make easy calculations. It's very good for ECMO. It's connected to that. Let me make sure I'm on MediWeb Studio on my thing. And let's see if we can make this connect now. No, it's not. See, see what it's doing? It's just doing nothing. It's just going around in circles looking for something to connect to, and we had it connected earlier. And I just don't know what else to do with it. Yeah, that's all right. Let's just move on. I'll worry about it later. Maybe we can figure this out. Hey, Magic, you want to just grab my phone and just turn it off and turn it back on? Oh, he's not here. Okay. So let me do that. I'll turn my phone off, and then I'll turn it back on in a few minutes. Let's go ahead and get started on the talk today. So my talk is Principles and Modes of CRRT. And actually, this lecture was done. I made a few modifications to it by Vicki Carlisle, who is our ECMO specialist director and also our nurse planner for all of our nursing programs. And of course, I think a lot of people consider CRRT to be a nursing thing. I've been talking about it for, many years now. It's got to be at least a decade that I've been discussing different modes of CRRT and the value that it has. And of course, we use CVVH, and the problem with CRRT is the name, Continuous Renal Replacement Therapy. Now, I know a lot of nephrologists who are brilliant people, and I also know a lot of nephrologists who are probably very brilliant, but just cannot grasp the concept of how CVVH works. And I'm going to try today to kind of get through that with you guys and see if we can make this work. Hey, Magic, could you do me a favor? if I give you my phone, and I already reset it. Oh, you have it? Here, can I see your phone? Can I use your phone? Let's go ahead and show you this app. I'd really like to do that. Thanks, man. I don't know how you got it. I couldn't get it. All right. That's cool. Oh, no, that's not it. Yeah, there you go. So there's the app. So this is what it looks like when you open it. You have a perfusion section, an ECMO section, hemodynamics section, a clinical calculator, an IV calculator, which is also a standalone app. And that app actually is really popular amongst nurses. But the standalone IV calculator, I think, is 99 cents. The app is $2.99 for the perfusion and ECMO section. And you get the IV calculator in it. So it's really affordable. I think we should go up on those rates. So if you haven't already found this and bought it, I really suggest that you do. But I'm going to show you kind of what I do in the morning. Is I go to perfusion and I go ahead and click on, and here's all the different things that are there, right? You get it all. You go to perfusion quick calcs. That's first thing I do in the morning, or whatever time it is that I get there for a case. So I'm going to have a woman. She's 65, and that's this basically her age. You put it in. I'll put in she's 66. Her pre-op hematocrit is going to be, I'll say 32. Not too bad, but not horrible. I'll give her a height of 170 centimeters. I'll give her a weight of 76 kilos. My pump prime, say I'm really, really good this day, and I'm down to 800 cc's. Anesthesia gives volume, and they give, let's say, 1,500. That's probably not atypical. And then our urine output, which we can recalculate. I'm going to show you that, which I think is very interesting. We're just going to say it's 500 cc's. You get your BSA, your BMI, your estimated blood volume in milliliters, red cell volume, your heparin dose based on 300 per kilo, estimated on-pump crit, and what your protamine dose would be based on that heparin dose. And then here are all your calculated flows. But let's say anesthesia, so this patient's estimated on-pump crit is going to be 23.45. That's not too terribly bad. But let's say, for the sake of the discussion, that anesthesia was really careful and they only gave 1,000. But let's say the patient urine output was actually less, 250. You can go back and recalculate these things, and now your on-pump estimated crit's going to be, here it is down here, 24.36. So you see it's got a tremendous amount of utility. You can also go over here and you can calculate your oncotic pressure. Globulins are usually, on the lower side. We're just going to say it's 1, and your albumin level is 3.2. And calculate your COP is 19. You could see it's low. And anytime you click that little I, it will give you what your normal value should be. Okay, so this patient was a little low on both, but their albumin level was low. And that's really your greatest exertion force for your COP. But 23 to 29 gives you your normal values. You can, for example, go to your ECMO section. O2 remaining in E cylinder, you're transferring the patient from CT back. You have 1,200 PSI and you're flowing 4 liters per minute. You have 104 minutes on that tank left. You can feel at least a little confident that I've got enough gas in this tank, but we should always have an extra tank with us. So that's kind of that section of the app. The IV drug calculator is here. It does these things. The nurses, like I said, really, really, really love it. And we can go back. And I'm going to go ahead and give David his phone back. That's good. Thank you, David. I appreciate that. I'm glad that worked out. So here is this picture is of Willem Kalf. When he was at Mount Sinai. Now, this may not be when he was actually creating this, but I have to say I really, really, really like the seersucker suit. It's really, really, really good to see with the bolo tie and everything else. And he was Dutch. But basically in 1924, the first dialysis was performed in a human. And in 1943, Willem Kalf successfully treated a patient that was comatose due to uremic poisoning. In 1960, the first repeated dialysis patient was reported by Clyde Shields. And it's really interesting that Dr. Kalf did not patent his device, just so you know. But he also created an artificial heart. In fact, he was once quoted as saying that if human can grow a heart, I can certainly make one. Real interesting character. In 1977, you've got the use of the arterial pressure going back into the venous, kind of creating an AV shunt to drive through the dialyzer. And then in 1987, Peter Uldal up in Toronto incorporated a peristaltic pump for the dialysis circuit. And of course, we all know Toronto actually has some pretty famous people. That's one. Dr. Mustard is another. Dr. Tyrone David is another. Toronto certainly has put out a lot of really incredible things and people. So my compliments to Canada. What are the goals? The basic goals of CRRT is the clearance of uremic toxins, okay, basic metabolites, correction of electrolyte derangements, fluid balance corrections, and I think more importantly, fluid overload corrections, acid-base derangement corrections, improved hemodynamic stability, because you're not trying to accomplish something in a very brief period of time. We're going to talk a lot about that. And for the potential, though I think realized, removal of inflammatory mediators. What are the indications for, we can say, and I'm going to go into this a little more deeply, but CRRT, again, I'm going to say it again. The problem with CRRT is the name CRRT, Continuous Renal Replacement Therapy. Really what we're talking about here is CVVH, Continuous Veno-Veno Hemofiltration, or Continuous Veno-Veno Hemodiafiltration, CVVH-DF. You can also do CVVH-D, which is continuous veno-veno dialysis. That doesn't make a lot of sense to me to do that, but people do, and we're going to get more deeply into that. That's a therapeutic modality that I don't think is appropriate for this particular technology. Other indications, severe electrolyte derangements, uremic complications, uremic bleeding, toxicity from a variety of things. Could be metformin, ethylene glycol, lithium. It's been used in a variety of different toxic circumstances. And ICP, intracranial pressure, it's very interesting that there's been a tremendous amount of work. If you take a patient with a closed head injury and you're trying to manage their ICP pressure, their intracranial pressure, and you put them on dialysis and make any acute changes, the ICP will go shooting up. And of course, that's the last thing that you want to have happen. And with CRRT, that tends to not occur because, again, it's a much slower, longer process, but much slower when you're making all of these various changes, though you can affect changes very quickly, more quickly than I think a lot of people imagine. And it's all about what your effluent dose is, and we're going to get into that as well. What are the contraindications to CVVH or CRRT, as the case may be? Patient advance directives. I don't want anything done. That's an obvious one, right? Futile prognosis. Well, I can tell you I've seen this used in many, many, many circumstances as palliative care, and it really should not be used in that circumstance. It's hard sometimes in an emotional aspect of it, but it's not cost effective to do that, and it's not sustainable for hospitals to continue to provide these kinds of services at the cost that they do when the outcome is already determined, and this is just being used for palliation. inability to gain appropriate access. The number one cause of CVVH or CRRT therapy interruption is access. Access is everything. The way you make CRRT or CVVH work effectively is access. There's three things: access, access, access. If you're not on ECMO, access has to be through a temporary dialysis catheter, Maherker, Quinton, whatever flavor you so desire. Hooked into the ECMO circuit, it makes it way easier, and we're going to be talking about that in the second half of this presentation. And it's very interesting because it can work beautifully. Your access is so incredible, but you can also mess up, and we're going to talk a little bit about that. And of course, if you don't have or if you need to have your treatment outcomes reached rapidly, though I somewhat disagree with this. I think you can do it just as fast as you can with temporary dialysis. In fact, I think, or intermittent dialysis, if you will. And, you know, I don't think CRRT or CVVH is intended to replace intermittent dialysis. I believe they're complementary. But I have actually participated in the care of somebody who was in the emergency room who had a potassium of 8.6, and they needed to dialyze that patient rapidly. They did not have in-house dialysis. I had a CRRT machine available. It was going to take them until the next morning, and this was about 9 or 10 o'clock at night. They weren't going to get there until 7 or 8 o'clock in the morning, and that was just not going to be acceptable. So we put that patient on CVVH in the emergency department, eventually transferred the patient to the critical care unit, and the patient did fine. So you can affect change very quickly. We could bring that potassium down. When I do my systemic hyperkalemia cases that I've talked about, you know, many times, we will drive the potassium up to 13, 14, 15, maybe even sometimes higher. The most recent case that I did, I gave the patient 400 milliequivalents of potassium to get his heart to stop and stay stopped while they did the mitral valve. And I was able to bring that back down to under 5, 4.5, 4.6 in about probably about 45 minutes, which is pretty remarkable if you think about it, right? And of course, if you do not have trained personnel or equipment, you ought not be doing anything that you don't have the appropriate training or equipment for. You know, always seek expertise if you can. I'm a big time believer in CRRT. I think that it is something that should be a standard of care available. But I also think it really needs to be used appropriately and correctly. And I'm going to show you some numbers in this that are published numbers, and some of them I'm going to fundamentally disagree with, and I'm going to explain why I disagree with them. The lecture's perfect. It's not anything wrong with the creator of most of these slides. It's what the published data is, and it's what's typical. But my experience tells me that that typical doesn't work as well as other things. And I'm going to talk about those as we move along here with this lecture. The most common machines available today is the Gambro Prisma Flex. Probably a lot of people know that, but I also put an image up there of the Prismax. So this is the Prisma Flex, the big green machine, and this is the Prismax, which is a later generation of this machine. You have Next Stage by Fresenius, and you have the B. Braun Diapact machine. Full disclosure, I have zero financial interest, or any interest for that matter, in any of these companies. It is purely my professional opinion that the Prisma Flex and the Prismax are the best widgets on the market to accomplish your goals with CRRT. By no means perfect machines, but comparatively, that is my professional opinion that they are the better technology. The most common fluids that we see, and I'm going to try to blow these up, There's a variety of them. There's Prismasol, there's Duosol, there's next stages version of these fluids. So I want to make sure everybody understands that there are a variety of places where you can get fluid that is appropriate for CRRT and CVVH. You can, but it would not go well, utilize normal saline. You can try to make your own. I've done it before with you can create your own fluid. Very, very challenging to do, however. Much easier to buy it off the shelf. The biggest problem with these fluids, and I really would love to use these as priming solutions as well, the problem with them is they come in 5-liter bags. They don't come in 1-liter bags. They don't come in 500 bags. They don't come in 2-liter bags. They don't come in 3-liter bags. They come in 5-liter bags. And even I'm old now, but even when I wasn't so old and a little stronger, have a hard time picking 5 liters up and hanging it on an IV hook. It's a little more challenging, and it's heavy and difficult to manage. It'd be nice if we had these things a little in smaller bags. But in the brawn version of Duosol, it's the one that I have up here, they're all very similar. You can see that they have different colors for different potassium levels. And that's to avoid somebody using 0K fluid. So they have some protective measures in there. I use the 0K fluid when I do the systemic hyperkalemia because the larger my gradient, right, of my replacement fluid, the faster I'm going to remove that potassium. But if you had a patient in the ICU where you only wanted to get their potassium down to 4 and it was 7, you might use a 2K bath or a 4K bath because they have all kinds. So I'm going to go ahead and blow up this formula here. And what you notice is it is a bicarb-based fluid. Okay, this is the 0K. And the 0K has 35 of bicarb that you see here. But it has sodium, it has potassium, calcium, magnesium, chloride, lactate is 0, as you can see here. So if you have a lactic acidosis, you're going to clear the lactate. If you have somebody on high volume CVVH, and your lactate level is 15, 16, and not coming down or slightly increasing, you got a big problem because the sieving coefficient, how fast you remove that with CRRT is 1. So if you have good high flow CRRT going on, you're removing lactate, which means it's continuing to build. If your lactate's not falling and you're on CVVH, you have an ongoing problem. And that's something that you have to be aware of, is not unlike ECMO, where you have the patient heater cooler on at 37 degrees, but you turn it off and the patient's temperature is actually 40 because they're really febrile, they're septic. You can mask a problem. With CRRT, you can also mask a problem. So you have to be aware of what you're doing, but you clear it, which is great, okay? You get the sodium corrected. You can try to get your pH corrected, your glucose, all of these things. And you see the different formulas. You got a 2K, you got a 4K fluid. But again, there's different companies have different formulations, but all of them are bicarb based, which means you're not going to have to keep administering bicarb if you use these fluids. So access typically is a dual lumen temporary dialysis catheter between 11 and 14 French. The access port, you want proximal to your return port. That's sort of obvious to everybody, I think. The best locations, actually, the 3 best locations for temporary dialysis catheter, Maherker catheter placement, is the right IJ, the right IJ, and the right IJ. However, right IJ is absolutely the best. Femoral, left IJ, and of course, you can put it in the subclavian. You will tend to have more recirculation. You will tend to have more catheter failure in the other locations. The nice thing about the right IJ, it's just a straight line, right? It just goes straight up and down. It doesn't have any curves, and it's extremely important to remember that temporary dialysis catheters are intended to be hubbed, meaning you don't want part of the catheter sticking out. They're very susceptible to damage. You want that catheter buried in the patient with the harder part of the plastic right up against it, approximated to it. Fistulas are absolutely not suitable for CRRT, and of course using ultrasound guidance really does help in terms of inserting these things. What is dosing? So you have an effluent dose, and what does that actually mean? So everything that I talked about has to be predicated on a basic conceptual understanding. You're going to be taking whole blood out of the patient. You're going to be passing that whole blood through your hollow fiber filter, your dialysis filter, CRRT filter. They're basically the same. You're going to remove the plasma water from that whole blood, therefore concentrating the whole blood that comes out the other end of your filter. At which point you are going to put a fluid like that Duosol with the formula that you want the plasma water to look like. And then it's going to go back into the patient, now reconstituted. So basically your replacement fluid rate, if you want it to be zero balance, should match, or has to match, whatever you remove in plasma water. That's the same as Z-buff, something we're all used to hearing on cardiopulmonary bypass. You go on bypass, you're removing, you have a high K, you start pulling fluid off, you give some normal saline. Of course, it has no potassium in it. You drive the K down, but you know you're going to have to give some bicarb. And of course, you give bicarb, and your sodium level goes up, and it becomes a vicious cycle if you're doing that with a large quantity. Excuse me. So, very important to understand the basic concept. You're taking whole blood, removing the plasma water, replacing the plasma water somewhere downstream with a fluid that looks like what you want the plasma water to look like in the patient. So your effluent dose of 20 to 35 milliliters per kilogram per hour is published by KDIGO, which is the Kidney Disease, I can't remember what that, Improving Kidney Disease, Improving Global Outcomes. That's KDIGO. They recommend 20 to 35 milliliters per kilogram per hour of replacement or effluent. So again, everything has to be balanced, zero balance. You can increase the patient fluid removal, but the machine's default is going to be zero patient fluid removal. I take off a liter, I'm giving a liter. I take off a liter, I'm giving a liter, but it's doing it on a continuous basis. So if the patient weighed 100 kilograms and you wanted to do higher dose, 35 milliliters per kilogram per hour, your replacement has to be 3,500 milliliters per hour, which means your removal, your effluent dose, is going to be 3,500. So there's all these terms, but they all basically mean the same thing. There's just different ways of saying it, if you will. I'm not sure, prescribed versus delivered. Oh, okay. So it's generally speaking, the filters are supposed to last 72 hours. The average published is 21.5 hours before there's some interruption. That could be because the filter clotted or clogged. It could be because you had to take the patient to CT. It could be because you have to stop it to change the bags. There's a variety of reasons why there's some interruption in therapy. So they recommend going up 10 to 15% of your prescribed dose to accommodate the fact that you're going to have interruptions. It's a 24-hour-a-day therapy, but you're only going to have 21.5 hours in the best of circumstances because of just naturally having to stop the therapy during the course of the treatment. Higher doses are beneficial in severe metabolic derangements if you have very high ammonia levels, quicker correction of hyperkalemia, But it's very important. The filtration fraction should not exceed 20 to 25%. Now, what is the filtration fraction? Well, the filtration fraction represents, in human physiology, right, the proportion of the fluid that gets to the kidneys that passes into the tubules. So in in CVVH world, what that basically means is the blood, and there's a big long formula. I'm not going to go over the formula with you. It's a big long formula, but basically you're taking, remember I said whole blood, it's going into a filter, you're removing the plasma water or a portion of it. The more of that you remove, that's the filtration fraction. If I take 20 or 25% of that plasma water, it makes the blood thicker. Well, thicker blood is going to pass more slowly through the filter, and you run the risk of clogging it. So to keep your filter healthy, you don't want a filtration fraction to be more than 20 to 25%. But sometimes you really want higher ultrafiltration rates. And the thing that I'm going to get into eventually is increase the blood flow. But if you have crappy access, you can't increase the blood flow because your access won't let you do it. So your therapy is not nearly as effective. And of course, we'll talk about connecting it to the ECMO circuit, which just makes things so much easier. But I do not recommend us putting people on ECMO just so that we have good CRRT access. Okay, I want to make sure that I make that disclaimer. But that's the reason why the filtration fraction through your CRRT dialysis filter shouldn't be higher than 25%, because you're basically going to be super concentrating the blood, and your risk of clogging your filter at that point in time increases. But filtration fraction in human physiology a little bit different, but means the same thing, right? Several studies and meta-analysis do not show any change in mortality in high dose compared to standard dose CRRT, but Dr. Ronco, so there's three really big names in CRRT. There's Dr. Ronco, who's out of Italy, Claudio Ronco. I've met him once, and he is such an interesting character. It's been many, many years. I don't know what he's doing now, but it was many years ago, and I had an opportunity to meet him. I went to a meeting in San Diego, the CRRT meeting, and there were some really smart, really good people there. I've always enjoyed this as something that I'm involved in. I know it's not classic perfusion per se, but I think that it does have enough similarity. You've got 5 pumps, 1 blood pump and 4 other pumps doing something, and it may not be a perfusion circuit where we're taking blue blood and turning it red in the classic sense of cardiopulmonary bypass, but it really has such a role, I think, in cardiac surgery, and can be used, especially with critical care, certainly, but I think in cardiac surgery as well. But Dr. Ronco, he tested a dose of 20, 35, and 45 milliliters per kilogram using CVVH, and he definitely showed a survival improvement in the higher doses. The VA also did it, and they compared IHD, CVVH, SLED, which is slow, low efficiency dialysis. Dialysis treatments usually last 3 hours, 4 hours. You do dialysis for 8 hours, 6 times a week or 3 times a week. But the groups were based on the SOFA score, which is the sequential organ failure assessment score, and they saw no difference. So I think it's important to point that out. Randomized evaluation of normal versus augmented level, and this is the renal trial, and they found that at 40 or 25 milliliters per kilogram per hour, diffusion or convection or mixed, there was no change in mortality. So, you know, there's one study from Ronco and 2 studies from the VA and from the renal trial. I don't remember who did that, but they didn't show any difference. Anecdotally, my experience is it makes a big difference depending on the patient's overall condition. If they're really, really in trouble, I think the higher doses stabilize them much, much faster. You don't have to keep it there, but I think in the short term it does. And I told you there were three big names. There's Dr. Ronco, Claudio Ronco. There's Dr. Bellomo, and he's out of Australia. And there's Dr. Dr. Maida, and he's out of, or was out of San Diego in California. Those are three really big names. And if you have an interest in this, I have Vicky put together a really nice bibliography on this of her references, and we'll post those so that you can take a look at them. But those are three names you can Google to get that kind of information from. Anticoagulation is a big problem. Clotting is the #1 cause of therapy interruption, and the #1 cause of clotting is bad access. Heparin is very commonly used systemically, or you can add it to a syringe and add it pre-filter. I prefer the systemic, but of course, if the patient is has HIT or something like that, you're not going to be able to do that. You could use Angiomax, but certainly if you're trying to do this without any kind of anticoagulation, you're just not going to have a good day. You can get away with it more with ECMO because your flows are so much higher for comparatively to even the increase in surface area. You have much increased surface area, I agree with that, but your flows are much, much higher in relationship. So with CRRT, you have much lower flows, 200 cc's, 300 cc's per minute of flow through a relatively large surface area. So it's very thrombogenic. You just simply can't do it. But, you know, you can, of course, you know, where heparin may be, or systemic anticoagulation may be contraindicated, you can do regional anticoagulation, taking advantage of that lower flow. And this was published by Dr. Talwani, and she's out of Birmingham. And you can find those protocols. Of course, it's not, it's one of those off-label things, but you can, utilizing the pre-blood pump, which basically is a line I'll show you in the circuit that brings ACDA up that line, decalcifies or chelates all the calcium in the blood, therefore anticoagulating it, and then returning it back to the patient, and then you systemically you give calcium to replace that, and there's specific rates in which you want to run that. So I'm not here to teach you all how to do regional anticoagulation with citrate. What I'm here to do is tell you that there are ways to do it and what resources or where you can find the information to do it safely. So there are some things, obviously, that will happen. You're going to be more prone to metabolic alkalosis, hypernatremia, hypo or hypercalcemia. It's very risky because you have to make absolutely sure that calcium is not infiltrated. You certainly don't want to use a peripheral line. You got to use a central line. You do not want, it's contraindicated in liver failure for obvious reasons. You definitely do not want to put the calcium in the CRRT circuit. Now, hypothetically, you can put it in the most distal port, but if you have recirculation, you're going to pull that calcium right back into your catheter, and it's going to clot your circuit out. So you do need two different places to do it well. Again, Ashita Talwani out of Birmingham, UAB, published this protocol, and you should look it up and read about it to completely understand that. But understand there are, of course, side effects to everything that we do. Dialyzers come with basic biocompatibility and the ability for clearance of larger solutes, which is affected by pore size and pore distribution, surface area, and wall thickness. If we're talking about diffusion versus convection membrane type, what their, it's not, I think, absorptivity, I think it's adsorptivity, where it will adsorb. So I think that's a typo potentially, or I'm just not understanding it. Adsorption filters, which are popular. I think the one that I really know about is Cytosorb. Cytosorb became very popular during COVID, and that is a cytokine filter which can remove very large inflammatory mediators by the process of adsorption versus filtration. You can't have pores big enough to remove those without losing plasma, and you don't want to do that. And they have some different ones. Baxter Gambro, which used to be Gambro, Baxter Gambro, they have a Mars system which takes the blood, removes the plasma, runs the plasma through a molecular adsorption filter, returns the plasma to the blood, ultrafiltrates it as well, and then goes back. But the Cytosorb is whole blood through one filter, much more simple to use than the Baxter Gambro. Theirs is called MARS, which is Molecular Adsorption Recirculation System. And there was an article one time, somebody who doesn't believe in that technology for whatever reason said no one has been saved sending them to Mars. I thought it was funny, but it's an interesting article to read. I do think that cytokine adsorption technology, however, like the Cytosorb, is very helpful for patients in severe inflammatory response syndrome or SIRS, which we're all familiar with, right? The basic principles of CRRT or CVVH, you have ultrafiltration, which is only a fluid transport, and you have diffusion, convection, or adsorption, which is a solute transport or reduction, whichever. Diffusion is the removal of small unwanted molecules from the blood using a selective concentration gradient across a semi-permeable membrane. Okay, we all understand what diffusion is. Concentration gradient, one side has a high concentration, one side of a semi-permeable membrane has a low concentration gradient, diffusion occurs. Obviously, the molecules move down their individual concentration gradients. If molecule A is very highly concentrated here at 0 here, but molecule B is higher here, but lower here, but not high and 0, then A is going to move faster than B, depending on size, if all things are considered equal, right? It has no effect on fluid balance of the patient unless you're doing ultrafiltration, right? If you're just doing diffusive clearance of selective solutes, then it won't have any effect on the patient's blood volume. The rate of diffusion is directly proportional to the concentration of the solute. That's common sense. Provides efficient clearance of small solutes between less than 500 to 1,500 Daltons, which would be 1.5 kD, kilodaltons. So pretty small. Clearance reduces rapidly with increased solute size. So the bigger your solute, the slower diffusion will take place, again, depending on the relative size of the solute to the size of the pores. This is countercurrent principle. You have blood flowing in one direction. You have dialysate moving here in the same direction, so your clearance will be reduced as you get further and further down. Here, what it's representing is blood going this way, your fluid going that way, or your dialysate, whatever you want to call it. And this is the countercurrent effect because you're going to have more clearance over a longer period of time. And that's how these things are intended to work. Not unlike our heat exchangers. In the old days, they used to be counter-current and flow. So you had blood going one way and you had your heat exchanger going the opposite direction so that you could cool or warm the patient faster. So I think we're all pretty aware of the counter-current principle and why that works. Here's just a representation photograph of, or diagram of basic diffusion flow of your dialysate going this way, flow of your blood going that way with the various solutes going across the membrane due to a concentration gradient. And here's just another representation of the same thing and how things move. You see the sodium's not doing anything because it's equal. Your K over here is 2, here 4.5. So your direction is going to go this way, but you're not going to go under 2. 2 is still too low, but if it was 4, it wouldn't go under 4 if this was, let's say, 7. But you won't remove it as fast. All of those factors. And then you can kind of look through all the different things. Very important to see here, albumin is 0. Albumin will not cross. Most of these dialyzers have a pore size of 50 kD, 50 kilodaltons, whereas albumin is 65 kD. So you're not going to remove albumin. You potentially could rupture fibers and have a blood leak, but you're not going to pull plasma across the membrane for anything, whether it be diffusion, convection, or anything else. Now they do have plasma filters that'll remove the plasma, but not the red blood cells, but that's a totally different technology. We're not going to get into that today, but it does exist. Ultrafiltration is the movement of water across the semipermeable membrane using a hydrostatic pressure gradient, or TMP, which is transmembrane pressure. Ultrafiltration accomplishes convection. Pressure on the blood side, inside the fibers, is higher, so water is forced across the pores, and dissolved solutes, that's called solvent drag, are pulled with it across. It requires, however, a pump to control it. So we all do cardiopulmonary bypass, we all do hearts, we all use hemoconcentrators, and you put it on there and just turn it on and it just free flows. And we have the luxury of our attention is right here. And it's what we do for a living. But if you're in the critical care unit and you're running something like this, you could imagine how much trouble you could get into. I don't know if you've ever done it, but I certainly have done it, where I've been on bypass, I've been ultrafiltrating, and I'm like, why is my level so low? Where's my volume going? Oh, I still ultrafiltrating, because I hook it up to a vacuum when I'm really trying to get a lot out in a hurry. So, and oh man, and then have to give some volume to replace it. But you can't do that in a critical care unit. The patient's going to code. We have the luxury of an open reservoir. I use a hard shell reservoir and vacuum assist, so I can manage that and it doesn't have any effect on the patient. Here's a basic CRRT circuit you have. Now, this is something else you have to really think about. And before we go, during the break, I need to talk about our ECMO course that we did. Would you please remind me? I meant to do that, and then I didn't do it. So at the break, I want to talk to you about our ECMO course, because this just reminded me of that. We just completed our inaugural nurse adult ECMO specialist course. In fact, Vicki Carlisle put all of that together. We had great participation. We have a didactic portion. We have a clinical wet lab portion, and you go to the wet lab associated with your clinical. It's approved for Category 1 CEU by ABCP. It's approved for CE credits for nurses, and it's also AMA PRA Category 1 CME for physicians. I mean, it's an incredible program, has incredible accreditations, and I was so pleased with it. I got to show you about some pictures from it. We had a great first class. I was so happy. You may want to look that up by going to mediweb.us. I think you can also find it on PerfWeb or Perfusion Education. So make sure you do that if you would. But in dialysis world, in perfusion, we turn blue blood red. Our venous line is blue. In ECMO, our venous line, which is our access, is blue. And we return it back to the patient red. So we turn blue blood red, and our line returning from the oxygenator to the patient is red. It has a red line on it, it has red tape on it, it's got something. So our blue is access, our red is return. It is 180 degrees different in the dialysis world. Your access is red, and your return is blue. Why? I get asked that question all the time, and there's a good reason for it. If you take blood with a, let's just say it has a PO2 of 160, saturation's 100%, 160 PO2, it's going to be red. It's going to look red. May not be Marlboro red, Marlboro cigarette red, but it's going to be red. If I remove all the plasma water, it has a hematocrit of 26%. If I remove all the plasma water of that same blood, don't change any of the other parameters, and make that hemoglobin instead of 20, or that hematocrit instead of 26, 38 or 40, it's going to be darker, right? And we're all used to that. We know that. We can look at blood and look what the hematocrit is by the thickness of it. But if you remove the plasma water, you have a higher hemoglobin content for the same oxygen content. It's going to be darker. That's why the return blood after ultrafiltrated through a hemoconcentrator is represented as blue. That's why it's opposite. Convection, we talked about that. Solvent drag, I've already addressed that. Ultrafiltration rate and sieving coefficient determines convective clearance. What is sieving coefficient? Well, sieving coefficient is how efficiently something will move from one side of a semi-permeable membrane to the other. If it's just easy to go across and all of it goes across, you have a sieving coefficient of 1. If very, 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 very little of it goes across, like barely, it's going to be 0.1. So a sieving coefficient of 1 is very high clearance. A sieving coefficient of 0.6, medium clearance. Sieving coefficient of 0.2 is very low clearance. And so that's what sieving coefficient, kind of how you use that term. It's non-selective, because all you're doing is pulling out the plasma water with whatever's dissolved in it that will fit through the pores. And a filtration fraction less than 25% if your hematocrit is 30. Again, for the reasons I already elucidated, right? The role of convective clearance is that it is highly efficient, just like diffusive clearance is, for small solutes, but it is much more efficient for larger solutes in the 10 to 20 kD or 10,000 to 20,000 Daltons. You will not remove anything at 10,000 kD or higher with diffusive clearance. It's just not going to happen. The concentration gradient may be there, but you just can't get those molecules to come across. There's too much of a mismatch. So you need something to help it, and that is not pulling it across, which we're going to talk about when we hook it up to the ECMO, but pushing it across. You want that blood side pressure to be much higher than that filtrate side so that it pushes the plasma water with what's in it across the membrane or through the pores. Inflammatory solutes, of course, have high generation rates, especially in septic patients. So you want to make sure that you're removing as much of the pro-inflammatory mediators, which are going to live in that 10,000 to 30,000 Dalton range. You want to be able to remove it, like TNF alpha, IL-6, IL-8, basically the evil humors that we're all sort of familiar with, the interleukins and the cytokines. Some of them are just too big or plasma bound and you're just not going to remove them. That's where the Cytosorb filter comes into play. But you can remove quite a bit and derive a tremendous benefit if you use this on patients prior to them getting to a point where Cytosorb would be the only thing that's going to help. But I think you need aggressive therapy. You're not going to do this. Depends on the patient, right? Your standard patient, you can get by with 20, 25 mLs per kilogram per hour. That's fine. Blood flow rate, the higher your blood flow rate, the better off you are. 300, 400, 400 would be fantastic. 300 would be great. 200, in my opinion, is too slow, but that is a standard. And of course, you have to be very careful because you don't want the filtration fraction to be too high because you're going to clot that filter off and you're not going to be able to continue with your therapy. The number one, the number one contributor to good CRRT, and I discussed this before, is access, access, access. If you have great access, you're going to have a really good run. Here's a basic idea of what convection looks like. You have high pressure on the blood side, low pressure on the water side, pushes it across. We talked about adsorption, so I don't really see a whole lot of point in this other than to point out that you can have inflammatory mediators that are up to 60 kD, that's 60,000 Daltons, 60 kilodaltons. That you want to remove, and of course adsorption is the way to do that. And adsorption, I think I described it earlier, but just for those who may not have heard it, you basically have a filter media, and these molecules, you have different charges. They come in different shapes and sizes, but by and large, the same idea. And these large molecules with a different charge will stick to it and adsorb versus absorb. Adsorb, stick to the filter media, and then when your filter becomes clogged, you remove it, put another one in, and start the clearance process again. And this is for patients who are just overwhelmed with very large inflammatory mediators in a real crisis. You have to be careful because you will remove antibiotics, any of those that have not been already bound to protein. That's free floating can be removed, including your antifungals like Flagyl. Here's just a representation, picture representation of what adsorption looks like. CVVHD, again, why? You know, I'll just say it. You know what I'm going to do? I'm going to write it. I'm going to put why. Why? That's a question mark. Why? It makes no sense. Basically, it's just continuous dialysis. And I think if you're doing continuous dialysis, then the patient probably, and that's all they need, they're going to tolerate intermittent dialysis. But if that's all you have, and that's what you got, and you don't have any dialysis, but you have this available to you, well, sure, that makes sense to do that. But it's not a cost-effective way to do that. Here is CVVHD, kind of what it looks like. You have your access coming here, going through here. This should be blue on your return. And you have your effluent pump, and you have your dialysate, and basically you're pumping the dialysate in this way. It's going counter current. Remember we talked about that, and going into your effluent pump bag, and then you just continue with whatever you want this to diffusively clear from there. But that's basically how that works. Dialysis is probably a much better way. I just, CVVHD makes no sense. why? I say, again, I would ask the same thing. Why? We're just going to move on from that slide. CVVH, now this makes sense because CVVH takes advantage of convective clearance. It is not dialysis, even though it falls under the title CRRT. And again, Dr. Ronco is a nephrologist, and I have a tremendous amount of respect for nephrologists. We have several here in town that I admire greatly. Dr. Mehta, Dr. Talwani, Dr. Balomo, these are all nephrologists who are extremely bright and really understand CRRT. But CVVH makes sense. It's continuous veno-veno hemofiltration. That's where you're removing the plasma water and giving back plasma water the way you want the plasma water of the formula you want the plasma water to look like. You're trying to raise raising the sodium is a different story. Let's say potassium. You have a potassium of 7, and you have a lactate level of 8.5, and you have let's say your sodium's I'll make it 132, your glucose is 75, whatever it is, and your magnesium is low, you put them on this, and if you remember back at the slide that I showed you, I'll just go back to it. Before too long, those are going to be your values, whichever one of these formulas you picked. So we're going to pick the 4K fluid, and that's what your numbers are going to look like. Your chloride's going to be 113, your sodium's going to be 4, your lactate's going to clear as long as you're not continuing to produce it, your calcium's going to be 3, your chloride or your bicarb's going to be 35, your chloride's going to be 113. So that's what it's going to be. And you can get a formula if you want a higher magnesium. For example, here it's 1.5, and that's what it's going to be. So very useful. Do you remember what slide I was on? Anybody? Okay. I think I'm here. Slow, nope, too far. That's diafiltration. Here I am. Found it. Okay. Here's what a CVVH circuit looks like. Access. Oh. Eventually. Yeah. Access coming here. This should be blue. Coming back to the patient. You have well, actually, going back to that previous one, since you're only doing dialysis, it's only representative that it should be blue. It probably isn't going to be a different color because you weren't ultrafiltrating in that CVVHD model. So I stand corrected there. But here you see you're removing the effluent, but your replacement is post-filter. So whatever you remove here, and remember, this is going to be 0 balance. So if I remove 5 liters here over whatever period of time, 5 liters here has to go back into the blood. And that's done automatically by the machine. The machine cannot add volume to the patient. They're all designed this way to not allow you to do that, so you won't fluid overload your patient, but you can increase the patient fluid removal rate. So I could have 6 liters of ultrafiltrate over some period of time, we'll say 24 hours, to remove a liter from the patient, but only give them back 5 liters. I can never take 4 liters from the patient and give them back 6 liters. That's not possible to do. Impossible. Here's representative basically of convection and how that works. We've beaten that up. We don't need to go over that. Why CVVH? Acid-base derangements, electrolyte derangements, uremia, fluid overload, basically the same reasons why you would do dialysis, but septic patients, greater removal of those mediators, those pro-inflammatory mediators that are larger. There is an increased loss of amino acids, greater with CVVH, so you have to take that into consideration when you're dealing with the patient's nutrition status. Typical order is a blood flow of 200 milliliters per minute, post-filter replacement of 2,500 milliliters per hour, and an ultrafiltration rate of 50 to 100 an hour to remove the patient's excess volume. I think this is too slow, and it really depends on the patient's weight. If the patient weighs, just for simple math, 100 kilos, then that's going to be 25 mLs per kilogram per hour. But if the patient only weighed 50, it's going to be 50 mLs. So these standard rates have to really be taken into consideration. What is the patient's weight? You have to know the patient's weight in order to prescribe CRRT in the correct way for milliliters per kilogram per hour. So keep that in mind. CVVHDF is just a more intensive therapy. It's where you're using every single pump. You got the blood pump, you got all the fluid pumps going, and CVVHD is continuous veno-veno hemodiafiltration. So you're doing convective and diffusive clearance both at the same time, and it gives you the opportunity to replace more plasma water because you're using all of the pumps to help you be able to do that. They call it the best of both worlds, high diffusion rates for hemolysis and high ultrafiltration rates for convection and increased adsorption. It says it's the most used modality. I don't really agree with that. I think that CVVH is the most used, in my opinion, but published, again, you have to take into consideration, this is published information versus my opinion and experience. This is what CVVH-DF looks like. We went through this circuit before. Access, return, you have dialysis going in and an effluent pump, and you have replacement going at the same time. And not unlike what I told you earlier, I can have, if I'm running 2 liters of dialysate and I'm running 5 liters of replacement fluid, this effluent pump, there has to be 7 liters. But I can't remove that much patient from the fluid from the patient, because then there would be 2 liters patient negative. And again, the way these machines are designed, it's going to understand this pump is at 2 liters, this is at 5 liters. It's going to take 7 liters, but it's not going to have the patient volume be negative, nor, as it cannot do, be positive. It just can't do that at all. These are some pretty, again, I think, and again, it's my opinion, I think that the Baxter, Gambro, Prismaflex, or Prismax are the better of the widgets at doing this. They are gravimetric, which means that they weigh the bags, and they have really sensitive scales. Now, that can be sometimes a pain in the neck, but it's very accurate, whereas a system like the Next Stage, which is not a bad, I'm not saying it's a bad system, I just don't prefer it, but it is volumetric, meaning it's counting revolutions of a pump head, and it is computing from that the volume. And that, of course, can have inherent inaccuracies. If you're a perfusionist, I think you inherently understand that. And as a critical care nurse, it's, I think, a very easy concept to understand. If you have an occlusion issue or you have an access issue and it's not your stroke volume of each turn isn't that, then you could have a mismatch. And if you read the product literature with the whatever volumetric system you want to use, it doesn't make any difference. They all recommend, and I believe it's at least once a day, that you physically measure in a graduated cylinder to make sure that everything is accurate. So I really believe gravimetric design is superior. We talked about why CVVH-DF. SCUF is nothing more than ultrafiltration for fluid removal. You're giving nothing back. You're just taking fluid off of the patient. Let's say they're fluid overloaded. They're tachypnic. You don't want to re-intubate them. You happen to have a catheter in place, or you put one in place. You run it through the dialysis filter or the hemoconcentrator, remove plasma water at some controlled rate. They start breathing more easily, go back to sleep, don't need to be intubated, and you've solved your problem. Sometimes giving Lasix takes a little while for it to work, and if they're laying there, and they're fluid overloaded, it's a nice, easy way to get that resolved. Why SCUF? It's basically just for fluid removal. PERT's very interesting. This is really interesting. PERT is prolonged intermittent renal replacement therapy, accelerated treatment. So during COVID, we had more patients than we had ECMO machines, and we had more patients needing CRRT than we had CRRT machines. So what they came up with was a more intensive therapy for a shorter period of time so they could move the machine from patient to patient. And this was basically something that was created out of the COVID crisis and lack of resources that existed. I thought it was brilliant. Why use PERT? And I just thought this is one of Vicky's slides, and very funny. I understand nephrology and other hilarious jokes you can tell yourself. I tell myself all the time because that is such a complex topic. Okay, do I have, I have to go through this test. So let's go through this test real quick. The main principles of CRRT are, and the correct answer is, correct, B, diffusion, convection, adsorption. The main benefit of CRRT to a critically ill patient is fast aggressive diuresis, slow more physiologic corrections, only diffusive clearance. Well, we know what it is. B, very good. Countercurrent blood flow of dialysate is important. Why? Because it helps maintain patient temperature, slows filter clotting, maintains a concentration gradient down the filter, prevents pulling too much fluid from the patient. If you selected C, gosh dog it, you are correct. Why is convection considered an important part of CRRT? The clearance of larger solutes is possible, is better at clearing small solutes, better tolerated by the patient, can use CVVHD mode. If you selected A, gosh dog this thing. Can somebody tell me what I'm doing wrong? Selected A, you were correct. To start a patient on CVVH, what orders will be needed from the MD? All that apply. Now, this is a trick question. To start a patient on CVVH, dialysate flow rate, okay. Replacement fluid rate, yes, you need that. Pre or post replacement fluid, you need that. Blood flow rate, you need that. Ultrafiltration rate, you need that. Dialysate, if you picked A, or if you picked B, C, and D, and E, you are correct if you didn't select A. Convection is the one-way movement of solutes through a semipermeable membrane with a water flow. Select the true statement in CVVH. Substitution fluids are not necessary. Well, we know that's not true. Molecular size of solutes do not affect clearance. We know that's not true. Occurs during hemofiltration. Only efficient for removing large molecules. I believe if you selected C, you are correct. Ultrafiltration is the movement of fluid through a semipermeable membrane along a pressure gradient. Select the best answer. Ultrafiltration is the movement of fluid through a semipermeable membrane along a pressure gradient. A, positive and negative pressures affect ultrafiltration. Positive pressure is generally on the blood side of the membrane. Convective solute clearance happens, or all of the above. I believe if you pick D, you are correct. Correct. Okay, and that is the end of our test. I don't want to keep doing the test because I'm going to eventually get one of these wrong, but you can all look them over if you like. Man, that's a long test. Vicky Carlisle's really rough. Okay, I'm going to take a 5-minute break. We have a comment? Okay, let me see. I put my glasses on. I can't see that far. We are using Fresenius multifiltrate, and it can take volume from patient if necessary. Fresenius. Yes, you should be able to take volume. I'm not sure. I don't know the Fresenius multifiltrate. It looks like you're probably coming from somewhere in potentially Eastern Europe. Huh? Belarus, okay. I welcome. I hope you guys are doing okay there. I hope you're safe and you and your families. I know that's a somewhat active area right now and that everybody's well. But I'm not familiar with the Fresenius multifiltrate. But it makes sense that with any dialysis system, you should be able to remove fluid from the patient, but you should not be able to give volume to the patient or fluid to the patient. You can in a zero balance setting, but you can't add volume to the patient through the system. Shouldn't be able to, but removing it makes sense. I hope that helped answer your question. Anything else? That's all? Okay. Can I take a 5-minute break? Would that be okay with everybody? Yeah, 5 minutes. 5 minutes. I'll be Hello and welcome back, everyone. Okay, so I do want to talk about something. And David, is it possible to bring up our MediWeb website? Yeah, you have it right there. Excuse me. I do want to show you this before we go any further. Maybe. Look, something is, I think it's still being shared. Something's, there you go. So here's our site with our adult ECMO specialist training course that you can see, and you can go to the site mediweb.us. Over here, you basically see our course pricing is there, our faculty page. Here's our schedule. We have completed this course, I believe, and our next course is going to be here in April 6th and 7th, with the didactic portion May 4th and 5th. So these basically are married to each other, as you can see here, and then it just continues to scroll down throughout the year. We're doing 5 programs this year, and I believe 6 programs next year, but this is very useful for perfusionists, for nurses, for physicians, respiratory therapy, if you have a strong critical care background. But I would go to mediweb.us to take a look at that. And I think we have from the simulation course, I sent David a video. I don't know if he can show it or not. You could see what it looked like. We were hosted by Memorial Hermann The Woodlands, which was an absolutely beautiful campus. They were so incredibly gracious to us, and we were able to do our program there. We had fantastic representation. We have both the didactic portion, which is not limited, but we also have the full course, which is limited to 12 people, so that everyone gets a real opportunity at hands-on. And I think David's going to show you a video from our course, which you'll understand why we have to limit the size. Maybe. What you think? There you go. That's perfect. And there's a couple of the nurses. There were a total of 12, and I think that I make a little bit of a pan around. That's good, Dave. Just go ahead and play it. And can you have sound? As long as they can hear it. People can hear it. Because the alarm's going off. There's the ECMO. They're trying to troubleshoot this issue. And we have everybody around. So there were groups of 3. 4 groups of 3, and they worked as teams in order to be able to manage these situations, and we kept people separate from each other that knew each other so that new connections could be made. Okay, let's go ahead and dive right into this portion of the lecture. Here is a basic ECMO circuit. We've discussed this, where we turn blue blood coming down the access line into the pump, going back to the oxygenator, turning from blue blood to red blood, going back to the patient. And here you see stopcocks, and of course one of my lessons in our course is never, ever, 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 ever connect a stopcock directly to a connector. Always use a pigtail, because if that breaks off, you're in a lot of trouble, and there's no repairing it. You have to replace it. You have to have a connector right there. It's going to be really bloody. You're going to suck air potentially. It's going to be very bad. Never, ever, ever put a stopcock directly on a connector. That's one of the lessons you learned in our ECMO course. And of course, here you see a heat exchanger, and you have an access port here. You have an access port here. One's pre-oxygenator and one is post-oxygenator. Colors are a little goofy, but everybody gets the idea. Here is your basic CRRT circuit. Access is red. It goes through a blood pump, gets pumped into the filter, comes back out, now ultrafiltrated, so darker, and goes back into the patient. You have your anticoagulant if you were using regional anticoagulation like ACDA. Again, Dr. Talwani's protocol online you can find. You have replacement fluid coming through a pump, which can be pre-filter or can be post-filter. You obviously have dilutional effect if it's pre and you reduce your clearance. You maximize clearance if it's post. Here is your ultrafiltration or ultrafiltrate coming into your effluent bag. And you can have this pump as either dialysate going this way, countercurrent coming out, or post-filter. So you can have pre-filter replacement and post-filter replacement at the same time. Now this circuit is the Gambro circuit. Again, each device is different. That's the Prismaflex circuit, and the Prismax is the exact same circuit. So now what do we do when we want to hook CRRT up to it? Well, there's several ways to do it. There's always many ways to skin a cat. It's how do you make it work and how do you make it work safely and effectively? So in this particular case, you have your basic ECMO circuit that you see, blood coming down blue, going in oxygenator, coming out red. And remember, red is now access, and you're taking it from the positive side of the circuit. This is a negative side, right? Always. And this is your positive side. Okay? This is positive as well. And then your pressure difference between here and here is your delta P, right? We all know this. So here's your blood going out of the circuit, going with a pump, so you're controlling the blood flow, going into, going into the hemoconcentrator, and it's going back in on the negative side. Now, you would imagine that if I have it connected to the negative side, a couple of things are going to happen. One, some of this blood is going to get recaptured, so you're going to have increased recirculation. Exactly. However, because the blood flow is probably 4+ liters per minute, and the blood flow through this is, let's say, 300 mLs per minute, you could see that the amount of recirculation that would occur in that situation is probably going to be negligible at best. So keep that in mind. What is the bigger problem is actually having this connected to the negative side, because this is probably going to be about -90, which means this is going to be -90, which means your effluent pump is going to be under negative pressure, and you're going to have to pull. Remember what I said earlier, you're going to have to pull the plasma water across the filter, and that's not how it's intended to work. And you can get into some real trouble doing it that way. So I do not recommend this technique. However, this technique will work. If you have this stopcock partially obstructed, you can create a back pressure. But again, that means you have to do that, but you have to remember to do it. And it can be done. Here is another way to do it. You have your access coming here from the positive side of the pump, going in, and you're returning it back to the positive side with this blood pump. Very challenging to do. It can be done, but basically these machines are designed to see certain pressures. Usually your access pressure is going to be negative, not positive. So if you're thinking about this circuit in a temporary dialysis catheter, your access is probably going to be somewhere around -70 to -100. Your return pressure going into that catheter, again, is probably going to be somewhere around +100 to +200, depending on the amount of blood flow, the amount of replacement, where the replacement is located, pre-filter, post-filter. All of those things are going to have an effect on it, the size of which catheter you use, and so forth. So when you hook it into an ECMO circuit where this might be -90, it could be -140. It could be anything like that. This can be +200 200, it could be positive 300. You could easily see where these pressures within the ECMO circuit are hostile to an overall CRRT or CVVH circuit. Here is yet another way to do this, where you're taking your access from the patient return limb of your ECMO with a roller pump controlling it, going in and going back to the negative side. Again, you're going to have the same problem. You have to restrict the flow going here, or restrict the opening in that stopcock in order to facilitate a back pressure against this. You don't want this to be under negative pressure. You don't want your blood side of your filter to be negative. It's not good for it. You want it to be positive. And you can affect that by restricting the outlet, increasing the blood flow. Increasing the blood flow here. All kinds of things, because remember, this is a closed circuit. Everything you do here will affect something else over there. Here's another way to do it. In this particular case, we're using the oxygenator access port coming up, going through the filter, and returning it to the access port on the oxygenator. Again, you can try to do it this way, but I don't recommend it. This again, are ways that it can be done that have been published. The problem with this is, remember, this oxygenator has resistance through it. So your pressure on this side is going to be higher than your pressure on this side, because you have the resistance through the oxygenator plus going to the patient, whereas here you only have the resistance going to the patient. And of course, remember, this is your delta P, or your difference in your pre-oxygenator versus post-oxygenator pressure. Very challenging to do it this way. And here you see going from the negative side going into the positive side. I think the machine's going to alarm a tremendous amount of times and not really work very well doing it that way. So really, I think this is probably the best. And with a restriction, putting some restriction here, this is the first one that I showed you, having this coming from the positive side. Now you could take it from there and have a little bit of arterialized blood recirculation, but again, remember, the flow is relatively slow, and through the hemoconstant, or through the CRRT machine, as compared to what it is going through the patient, 300 cc's versus 4 or 5 liters. So the amount of recirculation you're going to see is negligible and really not worth mentioning. So this is probably the best technique in order to be able to connect this to the CRRT machine to the ECMO. It can be done safely, but that's how I would do it. And we are crossing the finish line. I love downhill skiing. I don't know if you guys do, but I absolutely love downhill skiing. And there were so many pictures I could have chosen, but these people are fearless at the speeds that they're going and how much air they get, and the concentration and the balance. I find it absolutely fascinating. I do want to go over, if I can, real quick, and I'm just going to scan these pages because I think that the citations that Vicki put together are very important for you all to see. And I'll take just a second on each one of these pages so that you can freeze it and get them if you want. And there's Ronco, Belomo, and Kellum right here. Dr. Kellum, I also have met him before. Very nice man. He was up in Pittsburgh, but he's also very progressive in his thoughts. Good critical care medicine doc, but dialysis, a nephrologist as well. Nephrology and critical care combo. But you see Dr. Ronco's name a lot, and Dr. Belomo. And I think I saw, oh, that's a different name. There's that. And I believe that's it. We have concluded today's presentation. I think I'm ending a little early, and I apologize for that. I hope you will all forgive me for that. I'll try to make up the time on another program, but it's, as always, wonderful to see everyone. Please check out our app, please. I need to sell 1 million of them. I can retire from this nonsense. Number one. Number two, please check out our mediweb.us, our adult ECMO specialist course. It is a fabulous course. We have really worked so hard. It's been 5 years. I was ready to go and COVID happened and everything got derailed. But that course is, I'm so proud of everybody. I'm proud of Vicki Carlisle for putting that together. And she's also certified through ELSO as an adult ECMO specialist, which we prepare you for with this course. I'm so proud of Magic for all the work that he did in helping to facilitate all of the simulations, and David for all of his work and all of making all of this technology and integrating all of these different streams and videos and cameras and graphics and all of that stuff. I mean, this is required a village to do, and I'm just incredibly grateful for everyone. And at the end of the day, for those of you that watch this program and really find value in it, that's very rewarding to my soul, and I appreciate you all for that. We'll see you next time on our next Perf Web, whenever that may be. I can't really, April 12th. I'll see you April 12th at our next program. What's it going to be on? Hold on, we're going to look it up. We're going to look it up. Before I let you go, I'm going to tell you what it is. SARS-CoV-2. It's going to be something about COVID. And ARDS and Veno ECMO. So we're going to be talking about VV ECMO for ARDS patients that are their ARDS is from SARS-CoV-2. I'm so glad we're not in that anymore, but I think we learned so many lessons from it, and I think I'd like to share with you all of my thoughts and my experiences during that very difficult and trying time. Thank you all very much. We'll see you in April. Bye-bye.